Vitamin B6 deficiency presents one of the most striking examples of how a nutrient shortfall can mimic serious psychiatric conditions, yet it remains one of the least screened for and most misunderstood. The symptoms of low B6, such as depression, anxiety, irritability, fatigue, brain fog, and even confusion, overlap so closely with mood and neuropsychiatric disorders that they are often misattributed to psychological causes rather than biochemical imbalances. This misidentification is not just theoretical. In clinical practice, it's common for individuals to be prescribed antidepressants, anxiolytics, or stimulants for symptoms that may, at least in part, stem from a silent B6 deficiency. This problem is compounded by how subtle B6 depletion can be. Unlike scurvy or beriberi, which produce unmistakable physical signs, B6 deficiency tends to manifest as changes in mood, cognition, and neurological sensitivity, issues that are often harder to quantify and more easily ascribed to emotional or lifestyle factors. And because B6 is not routinely measured in standard blood panels, most patients, and even many clinicians, remain unaware of its potential role in what they consider mental health issues. In cases of persistent low mood, restlessness, or unexplained anxiety, B6 status is rarely evaluated unless a patient is already showing signs of peripheral neuropathy or anemia. The underlying mechanisms that connect B6 to psychiatric-like symptoms are well established. As paradoxal 5-foot phosphate (PLP), B6 serves as a cofactor in the production of multiple neurotransmitters: serotonin, dopamine, norepinephrine, GABA, and melatonin, all of which regulate mood, stress response, sleep cycles, and cognitive function. When B6 levels are inadequate, the synthesis of these neurochemicals falters. The result is an altered neurochemical environment that can easily lead to emotional dysregulation. For instance, low serotonin is linked with depression and obsessive thoughts. Low GABA contributes to anxiety and overstimulation. Low dopamine is associated with lack of motivation and anhedonia. Each of these states may be treated as a primary psychiatric disorder when, in some cases, the root is a functional vitamin deficiency. The tragedy here is that B6 deficiency is often easy and inexpensive to correct, yet people can go years or even decades misdiagnosed, treated with medications that don't fully resolve the issue because the underlying biochemical imbalance persists. This isn't to say that all mental illness is caused by B6 deficiency, of course, but that its contribution is frequently overlooked in cases that may not require heavy pharmacological intervention. What's more, individuals with marginal B6 status may respond poorly to psychiatric medications or require higher doses to achieve the same effects, which introduces a cascade of side effects and further treatment complexity. All of this might have been avoidable had nutritional status been properly assessed early on. Certain populations are especially vulnerable to B6 deficiency-related misdiagnosis. Women on oral contraceptives, for example, often experience mood changes that can be traced back in part to how estrogen increases B6 degradation. People under chronic stress also deplete B6 more rapidly, since stress-related pathways, including cortisol synthesis and detoxification, rely on PLP. Individuals with alcoholism, malabsorption conditions like celiac or IBS, or those on certain medications, including isoniazid, hydralazine, and some antiepileptics, are at higher risk of functional B6 insufficiency. Yet these risk factors are rarely cross-referenced with mental health complaints. Moreover, B6 deficiency doesn't only mimic mood disorders, it can also simulate more severe neurological and cognitive issues. Confusion, slowed processing, and memory lapses may resemble early dementia or cognitive decline, particularly in older adults. In extreme cases, prolonged B6 deficiency can contribute to neuropathy, which can be mistaken for diabetic complications or autoimmune issues. The resemblance between deficiency symptoms and genuine pathology further increases the risk of misdiagnosis and overtreatment with the wrong tools. An added complication is that low B6 levels are not always evident on standard serum tests. Blood levels may appear within the reference range even while intracellular or functional levels are inadequate. Functional biomarkers like elevated homocysteine or xanthorenic acid are more accurate indicators, but they are rarely used outside of specialized or integrative clinical settings. This gap in diagnostic precision further obscures the role of B6 in neuropsychiatric health and reinforces a system that treats symptoms rather than mechanisms. Ultimately, B6 deficiency operates as a clinical illusionist. It hides in plain sight, producing symptoms that look psychological but are, in truth, deeply biochemical. It reinforces the need for a broader, more integrated approach to mental health, one that considers not just psychological and environmental factors, but also the nutritional terrain that supports brain function. Addressing B6 deficiency doesn't negate the need for therapy or medications where appropriate, but it provides a missing piece that can make those interventions more effective, reduce side effects, and in some cases, remove the need for pharmaceuticals altogether. In an age where mental illness is increasingly recognized and destigmatized, it's vital that we not overlook the quieter, correctable causes hiding beneath the surface. Vitamin B6 may never be a blockbuster treatment or headline-grabbing discovery, but in many cases, it might be the key that unlocks the door to lasting emotional and cognitive balance.